Hello, everyone. My name is Krishay Sridala. I'm a first-year medical student at the Northwestern University Feinberg School of Medicine, and I'll be presenting this presentation along with Shri. I'll allow him to introduce himself right now.
Hey guys, my name is Shri. I'm a first year medical student at the Medical College of Georgia.
All right, and we'll be presenting the laparoscopic cholecystectomy. We'll also be joined by Dr. Rosser in a pre-recorded video, and he'll be describing the procedure itself. Okay, so here's a snapshot of the laparoscopic cholecystectomy. This is what we're going to be talking about today. So what exactly is it? The laparoscopic cholecystectomy is a minimally invasive surgical procedure that's used to remove a diseased gallbladder. Now let's talk about where the lap chole ranks in the most frequent operations performed in the US. So this is a list of the most frequent operations. For number one, we have the C-section, then knee arthroplasty, then perineal muscle laceration repair, hip arthroplasty, percutaneous coronary intervention, spine fusion, and then we have at number seven the cholecystectomy, femur fixation, colectomy, and vertebral discectomy. So as you guys can see, the cholecystectomy comes as number seven in the most frequent operations, so it's really important for us all to know about this. Now let's look at some numbers. How often is a procedure actually performed? So there are actually 750,000 laparoscopic cholecystectomies performed per year, and 90% of cholecystectomies in total are performed laparoscopically. That's why it's really important for us all to know about it once again. Okay, now let's talk about some indications for the lap chole procedure. Why exactly is it done? So, number one indication for the lap chole procedure is cholelithiasis, which is also known as gallstones. And then there's acute cholecystitis, which is inflammation of the gallbladder, and this can often accompany cholelithiasis. And then chronic cholecystitis, which is inflammation for an extended period of time. Then gallstone pancreatitis, which is basically where stones migrate into the bile ducts and cause pancreatic inflammation. And then choledocholithiasis, which is stones in the common bile duct. And then gallbladder polyps, which is abnormal growths of tissue in the gallbladder. And finally, biliary dyskinesia, which is where bile doesn't move properly through the biliary tract. And it's often a diagnosis given if it's not clear what the actual indication is. Now let Shri take over with cholelithiasis, also known as gallstones.
So I'll be taking over the cholelithiasis gallstones part of this presentation. First, we're going to go over the pathophysiology. And with pathophysiology, the main cause of gallstones is due to cholesterol imbalance. And in this case, these are called cholesterol stones. And with the cholesterol imbalance, it's due to an increased secretion of cholesterol that leads to just the buildup of gallstones. And in the two other more minor cases, 10% respectively for each of them are black pigment stones and mixed brown pigment stones. And in both cases, it's due to the deposits of calcium bilirubinate. However, the cause of these deposits varies. So for the black pigment stones, it is due to the hemolysis that leads to the increased unconjugated bilirubin. However, for the mixed brown pigment stones, it's usually caused by a biliary infection that leads to an increased amount of beta glucuronidase that leads to the increased calcium bilirubin deposits. The major predisposing factors and exposures of cholelithiasis are five main things: age and female sex, genetics, pregnancy, and weight-related diseases such as diabetes, dyslipidemia, and obesity, as well as any sort of medications like fibrates, cef this is a hard one to pronounce, ceftriaxone, somatostatin, which is a cholesterol medication, like we talked about earlier. A cholesterol imbalance is a major factor that leads to gallstones, and any sort of like statin analogs as well. Clinical manifestations. So this is how gallstones presents clinically in a patient. Most patients are asymptomatic, so that makes identifying the clinical manifestations obviously very difficult. But the most common symptoms are is a biliary colic. It's presents as intense dull discomfort in the right upper quadrant. So some diagnostic tests that we can do vary all the way from CT to MRI to HIDA scan. Ideally, we'd want to start with ultrasound because it has the highest sensitivity. And the tests that are ordered here are from highest sensitivity to lowest sensitivity. So ideally, if possible, we should start with the ultrasound, then the HIDA scan, then the MRI, and the CT.
Okay, now I'm going to pick back up here with treatment strategies. So how exactly are we going to treat cholelithiasis? All right, so first we need to talk about acute pain management. And as Sri mentioned, there's biliary colic, which is that right upper quadrant discomfort. And so that's going to be treated mainly with Bentyl. And Bentyl is a drug that's used to relax the intestines, and it's often the first choice actually for biliary colic. Also, NSAIDs are commonly used. But if these are both contraindicated, or if they provide inadequate pain relief, then opioids are commonly prescribed as well. So then we have to talk about subsequent management, and that's going to be the cholecystectomy, which we've been talking about here. But there are certain reasons why the cholecystectomy is not performed, and these contraindications are anesthesia tolerance, coagulopathy, and metastatic cancer. And if the cholecystectomy is contraindicated, something most commonly done is interventional radiology percutaneous drainage, which is basically a minimally invasive procedure where a catheter is inserted into the body to drain abnormal fluid. Okay, now let's go into some biliary tract anatomy. It's important to understand the anatomy of what's going on if we're then to understand the procedure itself. So I'm going to kind of walk you through this diagram here. First, we have the liver, and as we know, the liver secretes bile, which is important for the digestion of fats. And bile is going to go through the right and left hepatic ducts, and that's going to join into the common hepatic duct. And then bile will enter into the gallbladder where it's stored. So when you eat a meal, the bile from the gallbladder goes down the cystic duct, and which joins into the common hepatic duct, into the common bile duct. And so bile travels down the common bile duct and it goes into the intestines. And that's where it helps with the digestion. But it's also important to note that there's blood supply here, and the cystic artery is providing the main blood supply for the gallbladder. So it's important to keep that in mind as well. And now that we know the actual structures involved, we can start to think about the laparoscopic cholecystectomy, right? How is the gallbladder going to be removed? And as we'll see in Dr. Rosser's video, basically a cut is made here in the cystic duct, and then the gallbladder can be removed. So let's go into that. The movie by Dr. Rosser. It's a pre-recorded video.
Hi, I'm Dr. Butch Rosser, and it's been quite a journey with you guys. I just want to applaud all of you for all the great work you've done, the sacrificial work, the heroic work. We've had up to 60 people involved in the Top Gun surgeon squadron. And as you know, we always like adding a few new pieces. And the new piece that we're starting out today is our procedural clinical review presentation. And what we hope to do with myself, Dr. Petro, and Dr. Pill is to be able to show you a glimpse, a deeper glimpse of what we do each day, and that's surgical procedures. And today we're going to start off with one of the most common surgical procedures, well, the most common surgical procedure we deal with other than endoscopy. We want to show you the inside stuff with laparoscopic cholecystectomy. So I'm sorry I'm not there. I wasn't going to be going to our house in Florida, but my wife said, we're coming home and two of the five kids are there. So she got me a ticket to fly home because I'm going to be in Florida next month and over in the February for an extended stay. So forgive me, but right now I'm getting my soul right in church, okay? So thank you for understanding. So let's go ahead and share um, the video and let's get to it. Okay, as we mentioned today, uh, I'm going to be talking about laparoscopic cholecystectomy, but I really have to give a huge shout out to one of our Top Gun surgeon leaders, Julio Lamboy. Julio is the one that worked with me and put this video together. Julio, big shout out to Cornell. I'm so proud of him. He's been able to be on the wait list at the University of Buffalo, hopefully progressing on to the admitted list, but also he has other irons in the fire. Way to go, Julio. You have just been a huge leader and you stepped up in a big way. So, laparoscopic cholecystectomy. And this is where I initially became known. I was one of the first in the country in 1990 to perform a laparoscopic cholecystectomy, and then went on to work with the great leaders in Europe, and then come back here, and then subsequently, that's where my career started. I have removed the gallbladder with some of the youngest people in the world, 9 months, 12 months, and 15 months, and had to kind of reinvent the operation for them. So I have been doing this a while, and it's a great love of mine to talk about it. So right now, what you're looking at is a schematic of the upper abdomen where you see the liver, the gallbladder here, and it's not green, it's a pale blue. Then you have the stomach. Now, we call this area tiger country because there's a lot of stuff in here that if you injure, the patient can die. So this is not to be taken lightly by any surgeon, no matter how many procedures you have done. So yes, so this is the overview of the abdomen. We're going to get into what Crochet and Cherie actually went into with you briefly, and that's the anatomy. And I want to just congratulate both of these young men who are first year medical students. They worked closely with me to put together what I think is an awesome presentation. And now I'm going to try to own up to their greatness by giving you this video. So right now we're looking at the gallbladder here. You see the green outline here. That's to let you know that this is the biliary ductular system. And the gallbladder is a storage house, and a storage house for something called bile, B-I-L-E, that is produced in the liver. Now you can see how the bowel comes down and then goes into the gallbladder. And this storehouse waits for a strategic moment. And that strategic moment is when food then traverses the GI tract. You have the bowel, as you see here, mixing with the food, especially fatty food, to help with digestion. If you don't have bowel, you will not absorb the nutrients that you need. So here you see it going down the bowel mixing, and as I mentioned before, the gallbladder is the storehouse so that you have bile stored up to respond when you have a food challenge. Now, once again, we go back to our anatomy overview. And as Crochet and Cherie had talked to you about, there's indications to have your gallbladder removed. Several. We're going to talk about or show you these three. Number one, gallstones is the most frequent reason because it can cause pain and what we call biliary colic. Second, we have polyps, which can cause cancer, and then something called biliary dyskinesia, which is not that frequent at all. It means your gallbladder isn't functioning well, and you do not take your gallbladder out for this reason unless all other diagnostic efforts have left you with no other target to pursue. So those are the main reasons why we perform a laparoscopic cholecystectomy. Now, in the past, for instance, when my grandmother was a young lady at the dawn of the first golden age of surgery, you had to do this open. That's right. You had to open the body in a very large incision, with a very large incision that you're going to see here. And it was a morbid operation because you had to go across the recti muscles. You had to then close it. I mean, this is something that it would take up to 3 months to recover from, and 2 weeks or more in the hospital. Thank God that is not the case anymore. We are now pursuing the laparoscopic cholecystectomy, and this has been going on since the late 80s, early 90s. Now, let's now look at the laparoscopic cholecystectomy as to how it is done. We actually do this through little small tubes called ports that are strategically placed in the abdomen. Usually there are 3 to 4 of these ports. And as you can see here, they're strategically placed in the abdomen to be able to allow your long, thin instruments to be able to reach the target. The main visualization port is the umbilical port, and it is centrally located and gives you a great global view of the operative site. You also take the gallbladder out. Now you see this tube coming in. We have to, the abdomen is a potential space. To make it an actual space, we have to put in carbon dioxide. And we use carbon dioxide because it's more inert. It does not explode like oxygen. Back in the turn of the last century, in the early part of the 20th century, what would happen is they tried to use oxygen, and they had several, unbelievable accidents where they exploded the patient. Okay. Oxygen, as we know from NASA and Gus Grissom and his crew being killed on Apollo 1, this was shown how flammable and explosive oxygen is. So we use carbon dioxide, and you can see the tube coming in here, and that's going to inflate your abdomen to 15 millimeters of mercury. Now, one caution, you should not go over 15 millimeters of mercury in an adult, and over 7 to 10 millimeters of mercury in a child, because the pneumoperitoneum exerts pressure on the vena cava and decreases venous return. So you could have a patient actually go in cardiac failure because of lack of blood return to the heart. So if you look at this view right now, you see what we usually see as far as where is the strategic locations of the ports. You can see the centrally placed umbilical port with the visualization laparoscope. Now you start your fantastic journey within the body. And this is and we're starting off with the animation because it'll give you a more clean a picture of the anatomical structures in the process of the cholecystectomy. Now, if you look over here, the green, that's your ductular system with the common bile duct, the cystic duct, and Crochet and Cherie went over this with you. But also, look over here. This is your arterial cascade that you must be aware of. And remember, the cystic artery comes off the right hepatic artery and goes to the gallbladder, as you can see up here. As I mentioned before, this is what we call tiger country because the portal vein is under all of this. The hepatic artery is under all of this. And all of this can cause your patient to bleed out right away. And unfortunately, this has happened far too many times than we like to admit. Now you bring in your long, thin instruments that are going to come in, and your job is you have to put clamps on the cystic duct, as you see here, then clamps on the cystic artery, then that allows you to divide them. If you do not divide these structures that lead to the gallbladder, you cannot remove the gallbladder. And you see these 5 millimeter clips. Some people use clamps. And then once you ligate and divide, you are ready to put the gallbladder, as you see here, in a bag, and it is removed through the umbilical port usually. Now, when I had my laparoscopic cholecystectomy done, my partner, Jay Redan, the president of the ACS for Florida, he removed it through the epigastric region. Now, the advantage of coming through the umbilicus is that cosmetically, you never see the incision. So the gallbladder is removed through with a specimen bag, as we see here. And then what you wind up having to do is close that umbilical port because it is large, and you can actually have what we call an incisional hernia if you do not close this full thickness. Okay, that is a very significant complication that can lead to strangulation of the bowel. Now, I usually close, there's some people that close with glue. I usually close this with subcuticular plastic surgical sutures that absorb so that the patient will never have to have stitches removed. And I place these little steri strips, as you see here, over it. Now, let's go to the real thing now that I've educated you on how it's done. And bam. So let's do a survey. Here we are with the gallbladder. Okay, you can see that it's not green. It's a robin's egg blue. And guess what, sports fans? You can't see the cystic duct well. You can't see the cystic artery well. You're fortunate here because this is a duct that's enlarged. You can actually see the common hepatic duct coming down and having the cystic duct join it. And this is the common bowel duct. This is tiger country because the duodenum and the stomach is in the way down here in the southern region. So you got work to do because you have to now make what you see here look what you saw in the textbooks. Now, this is how you start. This particular instrument is called hooked cautery. It distributes electrical energy that cauterizes the tissues so they don't bleed. Now, the projected course of the cystic duct and the cystic artery is in this plane. You're mindful of the common hepatic and common bile duct because you do not want to injure this because that would be a catastrophic injury, and you will be finding out about these complications after the presentation. So usually, and this is one of our proteges, the Top Gun Squadron, Fernando Santos. This is a textbook presentation where you now get the superficial reflection of the peritoneum. You take that down first, and you take that in the area of the liver. Well, why do you do that? Why do you start there, Dr. Rosser? The structures you want are down here, because you have to achieve something called the critical view of safety. All right? The critical view of safety is what governs all of this, because you want to safely remove the gallbladder, divide the cystic duct, cystic artery, and not injure the common bile duct. And so you start with lifting the gallbladder from the liver bed before you actually start dissecting out the structures. Now, you notice you start superficial to deep. As you go, it's like being an artist in reverse. You have to have a picture that you wind up with, but you start by going layer by layer. And you can see what we call the back door here, taking down the tissue. And you see we're continuing to work to lift the gallbladder from the gallbladder bed initially. We're trying to establish our critical view of safety, and we want a window And see, this window should be right in here. You have an impression of a duct here, you still, which could be the cystic duct. You have an impression of a tubular structure here that you still can't see. So you have to mature this picture that you want to end up with. And like I said, it's in reverse. Now, bam. Now you had this view of what you think is the cystic duct right here, but now you see another tubular structure after your dissection come into view. Now, oh, there it is. Bam. There's your initial window. The cystic artery comes off the right hepatic artery here, and it usually splits into an anterior posterior branch. You have to understand that. This is the trunk. Here's the split. Now, what Fernando is doing here is basically a beautiful artistic job of maturing those structures, just like you saw with Crochet and Cherie. Now he goes back to lift the gallbladder from the gallbladder bed, because until you lift the gallbladder from the gallbladder bed and have those structures thoroughly seen, you have not achieved the critical view of safety. And he's doing a great job. You can see he's doing a lot of work here on the gallbladder in the front door, and we call this the back door. You can see the different layers, and he's going layer by layer. What a meticulous surgeon he is. I'm so proud of him. And you see the gallbladder lifted from the liver, which is this red stuff down here. So you have to put this work in to make sure you're going to ligate and divide the right thing. The most lethal injury with this procedure is the injury to the common bile duct. Now let's look in the front. He's done a lot of good work. Bam! Now let's survey the operative site right now. The gallbladder, the visceral side of the gallbladder where the ducts enter, has been almost totally lifted from its normal resting place in the liver. And down here, you have the cystic duct, and here you have a trunk of the cystic artery with the anterior branch, and the common bile duct is over here. Now, what you have achieved is the critical view of safety. Bam! Now you can see everything you need to see. Now this looks like Crochet's and Cherie's anatomical representation. Now and only now are you ready to, as you saw in the animation, clamp proximally, distally, and divide. Clamp proximally, distally, and divide. Boom. Now, there are times where you can't find those structures well. There are times when a stone will be, like in this particular picture down here, you see this white area against the dark, where you can have common bile duct stones. And you can see down here, this white loosened area. So you can take the cystic duct, put a tube in it, and actually do what we call a cholangiogram. The cholangiogram, as you see here, gives you a beautiful view of anatomy. Here's the right hepatic duct. Here's the left hepatic duct. Here's the common hepatic duct. Here's the cystic duct you see here, joining the common hepatic, turning into the common bile duct. There's the stone, and here you see the dye going into the duodenum. And this is a way to enhance your safety for doing this procedure and avoiding the most severe complication, which is a common bile duct injury. So guys, as I stop the share, I guess, that is the overview of the laparoscopic cholecystectomy. It's, it's besides endoscopy, it's one of the most frequent operations that we perform as general surgeons. That's why you do all that Top Gun stuff. You see how you have to have excellent targeting skills, two-hand choreography. You have to have superior targeting capability and a gentle touch. And you, by working through Top Gun, and for those of you that are Top Gun qualified, you are able to do this operation and do it with a level of safety eventually that is on a level in the upper percentile. I believe you can do it if that's what you want to do. So I want to just thank you all for attending today, our first lecture series in our clinical procedures a portion of our Top Gun Surgeon program. I want to thank you for all you've done all during the year. I want to thank you all who are working hard to go to SAGES. I can't say enough. My joy comes from serving you because it's legacy. That's what it's all about. All of you should be about, even now, thinking about how am I going to establish my legacy? And just remember this, legacy is usually established by not serving yourself, but serving others. Now I'm going to turn it back to Kache and Cherie, and also Dr. Petro will be entertaining the questions that I hope that you have. I want to say happy holiday season to all of you. God bless all of you, and you stay safe. And I look forward to working with you all again in 2025. Thank you.
All right, that was a great overview of the laparoscopic cholecystectomy by Dr. Rosser. And now we are going to get
Hi, I'm Dr. Butch Rosser.
we are going to get into the last portion of today's talk, which is complications of the laparoscopic cholecystectomy. So these listed here are the common complications, and Dr. Rosser mentioned a lot of them in his video, actually. And as he said, the most common one is common bile duct injury. That's captured here under biliary injury, also known as bile duct injury. So as Dr. Rosser said, that's basically traumatic damage of the bile ducts that occurs during the procedure. So this should be avoided. It's very common. And then there's biliary leak, which is where bile leaks from the bile ducts into the abdominal cavity. Biliary strictures is where narrowing of the bile ducts occurs, and that prevents bile from flowing properly. And then retained CBD stone, CBD stands for common bile duct, and that's basically when a gallstone remains or develops in the common bile duct after the cholecystectomy. And then post-cholecystectomy syndrome, which is where patients experience a series of abdominal symptoms after the procedure. Post-cholecystectomy diarrhea is diarrhea after the procedure. And then vascular injury or hemorrhage, and Dr. Rosser touched on this as well. It's basically injury that occurs to the blood vessels in the area. As you might remember, we covered the cystic artery, the main blood vessel in the area, so this is an important complication to know about. And then abscess formation, where an infection develops and forms a collection of pus in the region after the procedure. And then finally, bowel injury. That's traumatic injury that occurs to the bowel during the procedure. And yeah, so these are the most common complications, and their incidence is captured here on the right side. And these are our references. Thank you all, and that's the end of this presentation. We're happy to answer any questions you have. Dr. Petro is available right now, so you can unmute yourselves, put your questions into the chat, and thank you.
Yeah,
All
thank you
right.
so much.
Great job, guys. Those were phenomenal presentations. I am happy to take questions, whatever you guys have. Like you said, feel free to put them in the chat or raise your hand. Um, I'll just go back through. I just want to kind of add a few things. I thought your presentations were excellent. Took a few notes. I'll just kind of go through these one at a time. The first thing I wanted to bring up, when you were going through the indications, which was very comprehensive, and you guys did a great job of putting together all the indications of why you would need your gallbladder taken out. The one thing I do want to point out is that For cholelithiasis alone, it's really the stones that are symptomatic that get taken out. And so it's, I think it's important to step back and recognize that most people walking around with gallstones, they never need their gallbladder taken out. So, for instance, if someone comes to your office, and this is important when you students are seeing patients, and they have a CAT scan done for some other reason, it just so happens that they have gallstones. Most patients walking around with gallstones are not symptomatic. It's only when the stones get stuck in the cystic duct, sometimes they get stuck, and the gallbladder tries to empty, and that after a meal. Typically, we ask about eating greasy types of foods. And so if the gallbladder squeezes and the stone gets in the way, that causes pain. And typically for most folks, the stones kind of fall in and out and they intermittently will block the duct and then fall back out. And those stones are called, that's symptomatic cholelithiasis. If the stone gets wedged in the cystic duct for too long, and that creates back pressure and inflammation and eventually infection, then that's cholecystitis. And if that happens chronically, that leads to chronic cholecystitis. And many people live with this, unfortunately, for years, and sometimes just, the pain never quite gets to be bad enough until they see a doctor. If the stone makes its way into the common bile duct and causes back pressure up into the liver, that is called choledocholithiasis. And if it comes down and it irritates the pancreas, that's gallstone pancreatitis. And so a lot of these things that you have listed there are just a matter of where is the stone and at what time. And then um, and typically, in addition to the imaging, some lab work will help you sort out, where is the stone and how are we going to get it out? But for many of these things, the common pathway, most of them are going to end up with the cholecystectomy, which was what you guys really went into. The critical view of safety. So for the students that are eventually going to go through their, surgical clerkship, this is a super high yield thing. If you go through your surgical clerkship and you see a laparoscopic cholecystectomy, you are almost certainly going to be asked about closed triangle and the critical view of safety. And just to reiterate what Dr. Rosser was showing, the critical view of safety, it's really a logical argument. The goal of this operation, I had a surgeon, that used to ask when I was going through training, what's the goal of this operation? And most of us would reflexively say to take the gallbladder out. And he would say no. And then he'd go through, well, is it to take the gallbladder out safely? And of course, but eventually he would say, the goal of this operation is to not injure the common bile duct. And because, as Dr. Rosser pointed out, that is one of the most devastating complications. And so the point of the critical view of safety is to create a logical argument where by process of elimination that you are not going to injure the common bile duct. And so what the critical view of safety means is if that dissection is really good, there should only be two structures going into the gallbladder. One should be the cystic duct and the other should be the cystic artery. And if there's only those two structures and everything else is dissected out and all you see is the liver bed behind the gallbladder, then by logical process of elimination, you will not injure the common bile duct. And so that's why that view is so important. And then the other thing I kind of wanted to go into is the complications at the end. So there's, significant versus common. I think that one of the things I wanted to clarify was that common bile duct injury isn't necessarily the most common complication, but it's certainly the most devastating. And of all those things, so for instance, bile leaks are probably more common. Uh, we didn't show it, but eventually you put clips on the cystic duct and you divide it with a scissor. And sometimes that can leak, or sometimes you can even leak bile from the liver edge where you carve the gallbladder off. And so those complications are more common, but they're not quite as devastating. And then in terms of one of the more common complications, which is retained common bile duct stones, you can see that happens as frequently as 5.7%. So 1 in every 20 gallbladders you take out might have retained stones. And I'll just kind of throw this out there. Do you guys know if you have retained gallstones and you figure that out after surgery, does anyone know how you get those stones out? Anybody? So there's a procedure called, and this is kind of the other way to get to the bile ducts. There's a procedure called an ERCP. And essentially what that is, it's an endoscopy that goes down. And if you go through the stomach into the small intestine, you can actually get to the bile duct from that way. And oftentimes the gastroenterologist will do this, and they will actually be able to pull the gallstones through the bile duct in that way. So that procedure is a complementary procedure to the cholecystectomy that you just saw. The other thing, there's a couple other things in terms of these, post cholecystectomy diarrhea. That does occasionally come up. So oftentimes, if you see patients in the office 2 weeks later, they might mention that. But it's not the kind of thing that's so significant. Like for instance, if you're counseling someone on having their gallbladder taken out, they might say, "Well, what's life going to be like without my gallbladder?" And the truth is that most people, the vast majority of people that have their gallbladder taken out, they they go on with life normally. There's not a lot of people be like, "Oh, I wish I never would have had my gallbladder taken out." That's not a real common issue. The diarrhea, if it does happen for most people, is not that clinically significant. It's transient. It tends to go away. All right. Any questions? I want to make sure I give you guys the opportunity. If you have any questions about what you saw, uh, that I can answer.
Hi, Dr. Petro.
Hey,
Can you
Lou,
hear
how
me?
are you? Yep.
Yeah. Krisha and Shreya, amazing presentation. Thank you for putting that together. So, two questions. The first is, so with ERCP and MRCP, right?
Mhm.
It's my understanding that you have to be specifically certified to do that. Not every general surgeon can
Mhm.
perform that. Is that the case?
ERCP, yeah, ERCP is one of the more challenging endoscopic procedures. You
Mm,
technically, as what's happening in the field of general surgery is everything is becoming so specialized that some of these endoscopic procedures that were done by surgeons in the past,
mm,
general surgeons at some point are having to give up some of this territory. So nowadays, most ERCPs are done by gastroenterologists. If you do general surgery training, there are
mm,
fellowships that have an endoscopy heavy component where you can also learn to do ERCP.
mm,
What is becoming more common as a general surgeon, rather than pursuing ERCP, is being able to do in the operating room laparoscopically, like Dr. Rosser was showing. So he put that catheter in the common bile duct to shoot the cholangiogram. There's
mm,
actually instruments that you can use laparoscopically, for instance, that you can put through the bile ducts while you're operating to get the stones out that way. So and that's called a laparoscopic common bile duct exploration. And there's kits that you can use where you put wires into the bile ducts and you can actually get the stones out. There's baskets. There's little tiny, it's called a cholecystoscope. It's a tiny little scope that you can actually put into the bile duct, and you can push the scope forward. And sometimes you can simply just, we call it like a headbutt. You push the scope and it'll actually push the stone into the duodenum.
mm,
Um, there's baskets, there's balloons you can use to dial up the sphincter at the bottom of the common bile duct so that you can, again, push the stones, or sometimes simply just flush them through with saline. The easiest thing that you can do is, once you have those catheters in there to shoot the cholangiogram that Dr. Rosser showed, is to simply take saline and push really hard and flush. And a lot of times, if there's tiny little stones left behind, you'll flush them right into the small intestine so they're not retained.
I see.
MRCP is just an image, and sometimes for instance, if you think a patient needs an ERCP, based off often it's determined by lab work, and so if you get lab work, and commonly we'll use total bilirubin as an idea of if there's a blockage in the common bile duct, and if that's elevated, then sometimes the gastroenterologist will ask for an MRCP just to confirm that there are actually um, stones in the common bile duct. Um, but it is controversial if before surgery, if you think there might be stones in the common bile duct, depending on how elevated some of the lab works, some of the liver function tests are. Sometimes,
Mm,
if you have an endoscopist available, they'll get the ERC beforehand and decompress the duct. Particularly, that's most important in the setting where the stone isn't just there, but it's causing such a blockage that there's an infection in the common bile duct. Does anyone know what that's called? This is probably one of the more, in terms of, most of these things are urgent, but they're not truly uh, urgent but not emergent. But if you have an infection in your biliary system, that's actually called cholangitis, and that can be life-threatening. That can cause sepsis. And so for some people, decompressing the duct with an ERCP is actually done first, and then you can go afterwards and take the gallbladder out. If it's not that severe and it's a more mild elevation in the liver tests, then sometimes you can just take the gallbladder out first, take the pictures of the bile ducts like Dr. Rosser showed, and if there are stones there, you can try to get them out in the operating room through the common bile duct, or like I said, through a common bile duct exploration. That is an even more advanced, procedure.
I see. Oh, thanks for the detailed explanation. So
Sure.
it seems like you would then, in terms of order of tests, do an MRCP before you do an ERCP, right? Because ERCP uses X-rays.
Correct. ERCP is a procedure. That's the endoscopy.
Okay.
MRCP, yeah, they're two very different things. ERCP is the procedure done to actually go in, do the endoscopy,
Hmm.
and get the stones out through the sphincter of Odie.
Okay.
Um, an MRCP is simply an MRI with a special type of contrast that lights up the biliary tree that will allow you to see if there are stones.
I see.
Yeah.
Oh, so they're not always both indicated. It's just one or the other. Sometimes, most times.
Correct.
Okay.
Sometimes, if you're not sure, so sometimes what happens is liver function tests are elevated,
Hmm.
but then they come back down, and so sometimes it's a little ambiguous as to whether or not there might actually be stones in the common bile duct.
Gotcha,
And
gotcha.
so yeah, so sometimes you can get an image just to figure that out. Um, and there's a little bit of nuance depending on, exactly what the lab work shows. And oftentimes we work with the gastroenterologist to figure that out.
Gotcha. Okay, makes sense. Thanks.
Mhm.
I'll wait to ask my second questions if anyone else has a question.
I think everyone's being shy, Lou, so it's all you.
All right. So, since I will be starting rotation soon, this is very useful knowledge.
Hmm.
When it comes to the Carlos triangle,
Hmm.
and I'm assuming everyone's anatomy might be different. So I'm just curious what with the cases you do, the proportion of people who actually have an anomaly where you can't actually see the two structures, maybe you see three structures. And then what do? You move,
Hmm.
dissect closer to the liver or more into the gallbladder?
So that's a great question, by the way. If you get into a situation where you're doing the dissection, and let's say you don't have two structures, you have three,
Mm-hmm.
um, then a good thing to do in that scenario is to do a cholangiogram, because that will allow you to know, again, the whole point of the triangle, or the critical view of safety, having just the two structures, is to make sure you don't injure the common bile duct. And so one of the things that you're going to read about when you prepare for your clerkship is, when do you do a cholangiogram? Because some surgeons don't do it every time. If the anatomy is very straightforward and you have a critical view and you're not worried about having stones in your common bile duct because the liver tests were all normal, for instance, then you don't have to do a cholangiogram every time. Some surgeons you work with um, may do one selectively, so they kind of choose when they do it and they do it. And some surgeons will do it every single time. And so if you're working with someone who does it selectively, or doesn't do it all the time, then you have to figure out, well, when are the cases when you are going to do it? And so that is a scenario if you're ever not sure of the anatomy. And so that's a perfect scenario. You're doing your dissection, you've got three structures, you're not really sure. You can do your cholangiogram and really get an idea of, okay, this is the cystic duct, and the third structure that I'm seeing, I'm not sure what it is. Maybe it's a branch of the artery. Maybe the artery branches into two, anterior and posterior, and you just can see both of them.
Mm-hmm.
But the most important thing of that cholangiogram is it's going to show you that whatever you're seeing is not the common bile duct.
Oh,
And so selective cholangiogram will help you figure that out.
oh, makes sense.
Mhm.
Oh,
I had one question, Dr. Petro. This came up during my research into the diagnostic testing. I was just wondering more about the HIDA scan and how it's
Mhm.
used in practice for gallstones. I
Mhm.
understand it's basically helped to look at like the flow of bile and that's how to tell if there are gallstones obstructing. But is
Mhm.
this something done every time? Like if gallstones are seen in ultrasound, then do you do a HIDA scan, or how is it actually implemented in
Mhm.
practice?
So I would say HIDA scan is very helpful in when the clinical scenario is very confusing. And so in my world, a lot of times we will have patients who are in the hospital and have a lot of other things going on. So for instance, let's say they had a coronary bypass, they had open heart surgery, and they're recovering from that. And then after surgery, their white blood cell count goes up, and it's possible they could have a pneumonia. It's possible they could have a surgical site infection, and sometimes you'll get imaging that shows a distended gallbladder. And so the surgical team will get called and say, "Well, we're not sure where this elevated white count's coming from, or they had a fever last night, perhaps. Is it possible that the patient has cholecystitis?" And so if you have cholecystitis, remember I was going through the scenarios where stone goes in and out of the cystic duct and causes an obstruction. So by definition, if you have cholecystitis, the cystic duct must be obstructed. And so where a HIDA scan is very helpful is in that scenario where someone has a big distended gallbladder and you're not sure if it's infected or not. The HIDA scan will essentially what a HIDA scan is it gives the patient a nuclear tracer that's absorbed by the liver and then excreted by the liver into the bile ducts. And using imaging, you can see where that nuclear tracer lights up. And if the tracer goes down and it fills up the gallbladder, well, then the cystic duct must not be obstructed. Even so, that means that even though the gallbladder is distended, it doesn't look like that the patient actually has cholecystitis. And so in that scenario, it's in scenarios that are clinically confusing where there's a lot going on, particularly, if the patient is intubated in the ICU and can't really give you a reliable exam. And again, the patient has some signs of infection, and they're not sure if the gallbladder is the source. Those are scenarios where the HIDA scan is very, very helpful in saying, well, I know that the gallbladder filled with contrast. I'm not sure what the source of the infection is, but it really doesn't look like it's the gallbladder. The other scenario where HIDA scan will come up is this kind of vague diagnosis of biliary dyskinesia. So someone describes having right upper quadrant pain after a greasy meal, but on their imaging, they don't have any stones. And so surgeons will disagree on whether this is a real diagnosis or not. But if in those scenarios, if everything else has been ruled out, sometimes we will get a HIDA scan and we'll see if when they get the HIDA scan, they're given a medicine that helps the gallbladder squeeze. And if that recreates the pain that they were having, and so they will see how well the gallbladder squeezes. And if the gallbladder doesn't squeeze very well, if it has a low ejection fraction, then they will be given a diagnosis of biliary dyskinesia. And so whether or not that's a real disease or not, like I said, surgeons will sometimes agree to disagree. But that's the other scenario that the HIDA scan is sometimes used.
Okay, so basically, like if gallstones are known, then it's not really needed as much to hide a scan. But if
Correct.
yeah, if
Yeah.
it's more complicated, like in cholecystitis, then it might be
Yeah.
applicable. Okay,
Yeah, if they have stones, then they're seeing you in the office, then
yeah,
HIDA scan's typically not necessary. You could just go by the history.
okay,
It's when they don't have stones. So it's kind of like the two extremes. It's if
yeah,
they don't have stones and it's these you're trying to just make sense of their symptoms. It's helpful there. And then in these other super complicated situations where they have stones, they have a distended gallbladder, but I'm really not sure if that's the cause of their sickness. Then in those scenarios, it can also be helpful.
okay,
And then particularly for people that are very sick in the hospital. So for instance, a common scenario is someone had a heart attack and they had stents placed in their heart, and now they're on dual antiplatelet therapy blood thinners, where they're not really a good surgical candidate. If that patient has cholecystitis, let's say you do get a HIDA scan and it comes back positive, the gallbladder doesn't fill with the contrast. That's a good patient who can have the drain placed into the gallbladder a PTC drain. I think that came up in the presentation as well, where the gallbladder can be decompressed and prevent the patient from becoming sick. And that's a good temporizing procedure. If someone's too sick or on blood thinners and they can't have their gallbladder taken out right then the drain can be placed into the gallbladder to prevent sepsis, control the infection, and then once they improve from their illness, or for instance, in the scenario where they're on blood thinners, once it's safe for them to come off their blood thinners, then you can electively go in and take the gallbladder out. And for what it's worth, we do try to avoid that. Those cases when they eventually come to fruition, the gallbladder is very shrunken and shriveled up, and those are some of the most challenging gallbladders to take out, particularly laparoscopically. All right, everybody. So we're at 1 hour on the dot. Those were phenomenal presentations. Uh, and I thought you guys did a wonderful job. And hopefully we'll be able to continue this series of lectures in the future.